Imaging really impacts our thought processes and our decision making around breast conservation in a number of ways. So first, MRI is the most accurate to assess response to neoadjuvant chemotherapy or neoadjuvant targeted therapies, and that's been shown in several studies. And what we see is that it's the most accurate after neoadjuvant therapy to correlate imaging size of tumor with pathologic size of tumor. So just kind of giving us the most accurate estimate of what we should expect at surgery. So I really use MRI in these patients a lot, patients that are getting neoadjuvant therapy, because it's going to give me kind of a roadmap of what to expect. The other consideration though in these patients, especially we see hormone receptor positive and HER2 positive the most, is that calcifications, as of right now, we don't have a good way of kind of reconciling the fact that there's still calcifications in the breast and what that means for pathology. So you'll see calcifications at baseline and they'll stay stable, decrease, or increase. No matter which direction, there's kind of equal amounts of pathologic complete response or residual disease. So kind of as of right now, unfortunately, we need to excise the calcifications that started out, basically. We're finding more and more that axillary lymph node dissection can be avoided in many patients, especially those that undergo neoadjuvant therapy. So the subtype of the cancer really matters in this instance. So for example, hormone receptor positive breast cancer, those patients have somewhere between a 15 to 25% chance of nodal pathologic complete response. So they're not going to have the most robust response as defined by a PCR. And so it's difficult because as of right now, our axillary management algorithms and what we do for surgery when we do that completion axillary lymph node dissection really depends on complete eradication of the nodal disease. So not so great for hormone receptor positive. However, patients with, for example, hormone receptor negative HER2 positive breast cancer can have 90-95% nodal PCR rates. And so a really large majority of HER2 positive patients, you can expect that we can downstage the axilla, eradicate the nodal disease, and avoid the lymph node dissection. The last point I'll make is that the Keynote 522 regimen, adding pembrolizumab to our neoadjuvant chemotherapy, so now neoadjuvant chemoimmunotherapy, has really increased our rates of pathologic complete response in the triple negative population, and so we're seeing less dissections in that group as well.